Hello and welcome back. Now we're going to discuss about the answers to case 2, which was called a postpartum change. I hope you had the time to think about it. And so Miss Ursula Norman can be diagnosed as a case of bipolar 1 disorder. Actually, to be more precise, we divide the diagnosis into parts. So first of all, we say about the clinical diagnosis, which is bipolar 1 disorder. We describe the current episode. So the current episode, she's in mania, which is severe with psychotic features. And sometimes we talk about the onset. And here we have a peripartum onset. So this is how the DSM-5 likes to classify conditions now. And we don't do the whole axis thing anymore. So she has here bipolar 1 mania currently, and with a peripartum onset. Peripartum onset, I'd just like to elaborate further on that. Previously was actually known as postpartum psychosis. So women who gave birth develop symptoms of psychotic features after delivery. Not a really common condition. In average, the general population, 1 in 1,000 pregnancies have postpartum psychosis, but women who already have a diagnosis of bipolar disorder are one in every 4 women are likely with bipolar are susceptible to getting postpartum or peripartum onset of mania. So let's just so I talked about bipolar 1. I said she has bipolar 1. So that means there's a bipolar 2. What is the difference between bipolar 1 and bipolar 2? Very briefly, is that to diagnose bipolar 1, we need one or more manic episode, at least one or more manic episode. And we're going to talk about what is a manic episode in the next slide. Hypomania often occurs, and hypomania is basically a reduced version of mania. Okay, so mania is a full-blown picture, and hypomania is less than that. It's more moderate, and with, a level of functioning that's better than mania. And these patients nearly always experience at least one episode of major depression. So it's really rare for someone to just have a manic episode or 2 manic episodes without any depressive symptoms. Patients who do have that, though, are only 4% of the population. Okay, so if someone comes in with a manic episode, I will diagnose them as bipolar 1 and ask about history of depressive symptoms. And if they don't have depressive symptoms yet, it doesn't matter. I will just have watchful waiting until they do develop a depressive episode, if I don't keep them on medication, of course. As for bipolar 2 is I think, in my opinion, is slightly more tricky, because to diagnose that you need 2 things. You have to have at least one episode of hypomania and at least one episode of major depression. Okay, so at least one episode of major depression, that's not so hard to spot, not so hard to pick up. But at least one episode of hypomania, to actually really catch the difference between mania and hypomania, it can be a little tricky in the clinical setting, especially if the patient doesn't have a lot of insight or is not very communicative. So you obviously need an informant to help you out with that. And for bipolar 2, they have no history of mania, no frank mania. 5 to 15% will eventually develop an episode of mania, and so when they do, you shift them over to bipolar 1. So you re-diagnose them as bipolar 1 disorder. Now, we're talking about psychiatric diseases here. This is not a person who's just really hyperactive at one time and really depressed at another time. It is a pattern, a mood pattern, that it causes significant problems in the functioning of a person's life. This affects a person's life significantly, and it's not just known as mood swings. Okay, so here's how we tell the difference, or this is kind of a comparison chart between mania and depression. So what is mania? Mania, let me kind of tell you the textbook definition. The core symptoms of mania are abnormally and persistently elevated, expansive, or irritable mood, and increased energy or goal-directed activity. Okay. Mania could present either with elated mood, so a person is really happy, so euphoric, or could present as a person who is irritable. Okay. Or it could present with hyperactivity. So there's three actually main presentations, or two, main presentations of mania, either in the form of euphoric mood or in the form of irritability. So to classify mania, to say the person has mania, has to be for at least 1 week, okay, nearly every day, for most of the day. If it is with euphoria, or if it's with an elevated mood, then we have to have 3 out of the 7. Or if it's with irritability predomination, then it's 4 out of the 7. So here's the criteria: inflated self-esteem or grandiosity. So the person is very, very confident in oneself, confident in one's abilities. I can change the world. I've got these amazing ideas. I'm talking to God, and I'm, this blessed person. It's not a delusion. They're not delusions. They are just really elevated self-esteem. Then the next one is a decreased need for sleep. And this is, you have to be careful when you're asking about need for sleep. You first of all ask them, how many hours of sleep do you have a night? And they could say 2 hours of sleep. Now you need to actually further ask them about, is that because is that you sleep that small amount? Is it because you cannot get to sleep, you're tired and you want to sleep but you can't? Or is it because you actually don't feel that you need sleep, you've got enough energy to get you through the day, or to get you through the night rather? So that's what matters. And these patients usually feel that they don't need sleep. They have a lot of energy, they don't need that sleep. They're more talkative than usual, or have pressured speech. They have racing thoughts, or flight of ideas. They've got a lot of ideas rushing through their head at the same time. They keep changing topics. They keep jumping from one topic to another. Distractibility, so they're easily distractible, and all the sensory cues around them they're very very attracted to. So the door opens, they look at the door. The phone rings, they look at the phone. They can't focus very well on just one thing. They have increased goal-directed activity and psychomotor agitation, so they can't really sit in one place. They're getting up, they're doing things, trying to get a lot of things done. And they have they take part in excess pleasurable activity, in the form of like spending a lot of money, gambling a lot, having a lot of sexual encounters. And so we put mania as we call it a manic episode. It is not a pervasive pattern throughout the whole life of the person. It's not, I'm like this all the time. It is an episode in which they are, for every single day, or nearly every day, for most of the day, for 1 week at least, having these symptoms all together. Okay, 3 or 4 out of 7. Okay, so that's for mania. For depression, I think depression is very well known, that you have to have at least 2 weeks of these symptoms, and 5 out of the 9. So we've got 9 criteria here, and 5 out of the 9, and one of them must be either the first 2, either dysphoria or anhedonia. So let's just read them out. For the first one is depressed mood most of the day, nearly every day. So basically the patient feels sad, they feel tearful, they feel unhappy for most of the day. This is called dysphoria. For most of the day, nearly every day, for 2 weeks at least. Anhedonia, anhedonia refers to the inability to enjoy previously pleasurable activities. So, for example, the person usually really loves to go and watch a movie, or they love to go out with friends, but now they just don't feel any pleasure from doing that same activity. Everything just seems to be really bland for them. Okay. And again, we're gonna actually start using the word the acronym NED, which is nearly every day. Okay, so it has to be nearly every day. This is not just a 1-day occasion or 2-day occasion. It has to be nearly every day for 2 weeks. The third one is significant weight loss or weight gain, or a noticeable increase or decrease in appetite. So it could be either ways. People could lose weight and lose appetite in depression, or they could actually eat a lot and gain weight in depression. Again, with sleep, hypersomnia or insomnia, both. I spelt insomnia wrong. Excuse me for that. Okay, so hypersomnia tends to be a bit of an atypical presentation of depression. Usually it presents with insomnia, so the patient cannot get to sleep. Not because they have more activity, they have more energy, they don't. They're actually tired, they want to sleep. However, it could be due to the ruminations, excessive thought, worries and guilt that's preventing them from getting to sleep. Okay. The fourth one is psychomotor agitation or psychomotor retardation, and that's basically talking about their activity levels. So they are, or rather, do they move? Some of them move, feel restless and listless, and some of them feel like, I can't get out of bed, I can't move, I'm just going to stay in the same place nearly every day. Ned. Energy levels. So either it's not either. It's in depression, there is fatigue. There's a loss of energy. There's just a feeling of I'm drained. And we have thoughts of worthlessness. So esteem. Now we're talking about esteem here. They have very low self-esteem. They feel worthless. They feel helpless. They feel hopeless. They feel really bad about themselves and have inappropriate levels of guilt. Not just the levels of guilt that we have that are normal. For example, you don't come on time, or you do a mistake, so you feel guilty in a very appropriate level, but they feel inappropriate guilt for things that might not even have been their fault. And that's, again, nearly every day. Let's talk about cognitive functions. They have a decreased ability to think, decreased ability to concentrate. They can't really do focused activity. They can't study well, for example, because their mind is just cannot focus. And of course, we have to assess that, and very clearly in all patients that we encounter is the idea of suicidal thoughts, suicidal ideation, and suicidal attempts. And these are just levels of suicidal. So if you think of death, just the thought of death, like I will die, people will die, these are just thoughts. Suicidal ideation is actually beginning to think about plans of ending one's life, and actually attempting suicide is at the highest level, and we should assess that for all patients. Right, so let's go back to the case and try to apply why did we diagnose Miss Ursula here with the bipolar 1. So frankly, she's just a nurse who has, after giving birth, by 3 days she became abnormal. Her mood is the main complaint that her husband has been talking about. She has had abnormal mood, so she switches from happiness to weepiness. She's irritable, she's anxious, and she has a decreased need for sleep. So we've already spoken about the decreased need for sleep as one of the criteria. So let's start to highlight here things that might help us in diagnosis. So she's got a mood problem, okay, and it's rapidly shifting between elation and weepiness, irritable and anxious. So she's got irritability, okay, and she slept only an hour a night. So, and her sleep problems is not attributable to the baby, okay, and we need to ask about that. Maybe the baby's crying all night, so she can't get to sleep. Maybe it's not something to do with her. So we're actually meeting 2 criteria here. She's irritable, rapid shift in mood, and insomnia. Her behavior is becoming increasingly bizarre, and she has psychomotor overactivity and agitation. Her speech is rapid, okay, and now here we start to come into a feature that is not really a mood problem, but it could be a mood problem. It could be a mood problem, actually, because it could be just the grandiosity, the high self-esteem. She's thinking that God is talking to her, that she has special powers, she can solve the problems of the world. These are features of a person in a manic episode. They feel that they can do everything in the world. They could solve the problems, cure AIDS, I don't know, everything else. Another thing here is she said she could identify evil people by looking into their eyes. This could be also like magical thinking. She thinks that she's a very powerful person who can read people's minds and intentions, and she's begun to worry she's being surrounded by evil people, including her mother. These are signs of paranoia, and these are the things that could result you into thinking a little further. Maybe this is not just a mood disorder, but could be a psychotic problem. As we keep venturing further with her, she says, and she's completely convinced, totally convinced, I'm sorry, this highlight is getting out of hand. She's totally convinced that she smothered her baby, and nobody could convince her otherwise. So here we're actually getting into delusions. These are false, fixed beliefs that are not shakable, and she's convinced that she's killed her child, even though her child is not, and they're trying to convince her otherwise, but she still believes so. So here, in this paragraph over here, we're really starting to think about a manic episode with psychotic features. This delusion, these really strange beliefs, and that are non-shakable, would really make you think of a delusion. Let's talk a little bit about her past history. As we said, she has a history of major depression about 3 times. She had a history also of mania. So she's had a manic episode, and she's had 3 episodes of depression. So it's really clear that she was kind of already bipolar before she got pregnant and before she had her baby. So this is not the first time, and she was reluctant to accept the label of having a bipolar disorder. And she stopped taking medications because she was supposed to be getting pregnant. So her compliance is not really that high. Let's talk about family history. Her mother also had a history of peripartum onset of a psychiatric condition. We don't really know what exactly it is, but she was admitted to a psychiatric hospital. So it's clear that it was a distress, an indication for admission. Okay, and as you should know, that peripartum onset of psychiatric conditions, especially peripartum onset bipolar or psychosis or whatever, these are true psychiatric emergencies, because these conditions threaten the life of not just the mother, but of the baby. And so I think in most all cases of people with peripartum onset of psychiatric conditions, they should be admitted to the hospital and followed up and treated, and ensure that after she leaves the hospital that she's going to have a treatment plan that will help her to adjust to her new life. Something that excludes, for example, something like schizophrenia, is that before her delivery, she was a highly functional nurse. She was getting on with her life. She was functioning well. She was getting good with her life. She was a nurse in a renal unit. So she doesn't have a global dysfunction in her life. She is pretty much okay. She's great with episodes of mood disorder. And this is the feature of bipolar. And it excludes kind of schizophrenia and conditions like that. Okay, and we excluded illicit drugs, we excluded all other things. So now on psychiatric examination, we can see she seems unable to sit. So she's got agitation. She can't sit down. She's distractible. Okay, overly talkative, and demonstrated a flight of ideas. So she kept changing her ideas from one subject to another. This is one of the features of the flight of ideas and the racing thoughts. So we will go back to this again, but most likely actually she showed grandiosity already. She showed us a decreased need for sleep. She's more talkative than normal, as what her husband has said. She's got clear racing thoughts and flight of ideas from just the physical examination. She's distractible. She has psychomotor agitation. She can't sit in one place. She's moving. And as for the excess pleasurable activities, we still haven't really encountered that yet. Let's continue. Okay. Her mood was labile. She was euphoric at one point, and then she's tearful at another, and then she's irritable at another. So these mood kind of swings in the same episode are features of a manic episode. And it was clear that she had a number of delusional beliefs, but she didn't want to share them. And the main delusion that she seemed to have was the one that she's already killed her child. That was really kind of the main delusion that she seemed to have. And of course, with testing to see if there's harm to self or others, she did not intend to harm herself, and she presented with poor concentration. Okay, so I think we've kind of reached a very direct diagnosis here in Miss Ursula, with the diagnosis of a bipolar 1 disorder. So what's important here for us? Hang on. Okay, sorry. Is that what's important for us here is to identify that postpartum psychosis or peripartum onset is a true psychiatric emergency. These patients do need to be hospitalized and assessed and followed up, and frankly, I think that's all I want to say. Yes, I think that's it. And of course, we should discuss with her about the future pregnancies that she might have, and her medications and compliance and everything like that. That about rounds it up for this case. Thank you for joining me. I will be joining you for another case very, very soon. And thank you so much.